I'm going to be talking about how I do the Kохera Langgenbeka approach to the acetabulum. And we'll go through the usual indications, how to position the patient in theatre, the skin incision, superficial and deep dissection, and finally the closure. So the main reason for performing a Kохera Langgenbeka approach is an acetabular fracture, and it allows good access to the posterior aspect of the acetabulum. So any posterior wall fracture, any posterior column fracture, or a combination of the two are most commonly the indications for a Kохera Langgenbeka approach. There are other patterns of acetabular fractures that, that can be treated with this approach as well. So the reason it's a good approach to the posterior aspect of the acetabulum is as you can see here, the shaded area in blue shows what you can see directly with this approach. So you can see the posterior wall and the whole of the posterior, pretty much most of the posterior column from the sciatic notch down to the greater to the lesser sciatic notch. And then the shaded pink areas are where you can palpate and get a feel of these areas and affect reduction in a reasonable way. And so the image on the right shows the inner side of the acetabulum. So it's shaded the quadrilateral plate. And so with your finger through the sciatic notch, you can feel the quadrilateral plate. We'll touch upon the green area a bit later in this talk. So here's just an image of someone's finger through the sciatic notch, palpating the quadrilateral plate. I think it's quite ambitious. You probably can't get all the way to the front, but you certainly can feel the medial aspect of the posterior column and the quadrilateral plate through the posterior approach. So in terms of positioning in theatre, it's so I put them on a Jackson table, put them in a lateral position. You can do this approach through with the patient in a prone position, but I prefer to do it in a lateral position. I'm more familiar with that, and often the fracture pattern is easier to affect. The fracture is easier to affect in this position. There are some scenarios where a prone approach is slightly more beneficial, but we'll just talk about the lateral position today. I use a bean bag to avoid any interference with clamps when x-raying. The skin incision is not that dissimilar to what you're familiar with maybe with the posterior approach, so centered over the femoral shaft, the tip of the GT, and curved backwards towards the posterior superior iliac spine, as you can see here. And then the superficial dissection, again, not that dissimilar to your posterior approach to the hip, so an incision through the iliotibial band or the fascia, and then curved along the fibers of the gluteus maximus, as you can see here, splitting the fibers and being careful not to disrupt the neurovascular structures proximal to the proximal end of the incision. And then you're presented with this, this view. I sometimes take off the gluteus maximus insertion. That gives you a much more exposure to the acetabulum, and certainly in those young, big, muscular men, this is a really good step to do to give you a bit more exposure. So at this point, you're thinking, hang on a second, this is pretty much like the posterior approach to the hip. So what's the difference? You know, why is the Kохera Langgenbeka any different to the posterior approach? Well, the difference lies in the deep dissection of this approach, and the fundamental reason for the Kохera Langgenbeka approach is to preserve the blood supply to the femoral head. And as you know, this is predominantly or in a large part supplied by the medial femoral circumflex artery. And clearly, a posterior approach to the hip for a hip replacement, you don't need to preserve the blood supply to the femoral head. You're replacing it. Whereas when you're trying to achieve reduction to the acetabulum, the last thing you want to do is to disrupt the blood supply to the femoral head, develop AVN of the femoral head, and end up needing to do a hip replacement down the line. So we want to avoid disrupting the femoral head blood supply. So I have a few rules to go through. Rule number one is leave a 10mm cuff of piriformis tendon when incising the short external rotators. So here you can see that I've left a little bit, or that the image shows that I've left a little bit of a cuff and not taking the piriformis right at its insertion into the GT. And the reason for that, again, is to preserve the medial femoral circumflex artery, to preserve the blood supply to the femoral head, which you can see running here along the posterior ridge of the greater trochanter, up from distal to proximal. And here, this image is a nice image where it shows that the kind of blue area is the danger zone. So if you start making any incisions in the blue zone, you're at risk of damaging the ascending medial femoral circumflex artery. And so leaving a 10mm cuff when making an incision through the piriformis and the short external rotators, you preserve that blood supply. Rule number 2 is do not incise the quadratus femoris tendon. And so the reason for that is, so you've got the quadratus femoris tendon, which kind of overlaps the obturator externis at the back. And as you know, the medial femoral circumflex or medial circumflex femoral artery runs along the lower border of obturator externis. So if you make an incision that's proximal to the border of quadratus femoris, then you're well safe of damaging this medial femoral circumflex artery. So those are the 2 rules there. The third rule is once you've taken off the short external rotators, or as you're taking those short external rotators off, you need to identify the greater and the lesser sciatic notches to, in your head, know where you are in space, and you know where you find yourself in the pelvis, and you don't get lost. So you can see the piriformis tendon here peeled back, and as you peel this piriformis tendon back by dissecting between this tendon and the capsule, as you follow it down, you will naturally run into the greater sciatic notch. So you can see this image here. The piriformis runs out of the sciatic notch onto the GT. And so as you peel that piriformis tendon off the capsule, and then you follow that, tendon down into the pelvis, you'll naturally fall into the greater sciatic notch. So with your finger, you can follow down into the greater sciatic notch, and this is where you can palpate the medial aspect of the acetabulum that I showed you earlier on in the presentation. So the second thing to do is to identify the lesser sciatic notch. So you follow the obturator internis, and obviously this is less clear, but it's the rest of the short external rotators. And as you peel the rest of the short external rotators off the capsule, you'll fall naturally into the lesser sciatic notch. And here you can see an image of the obturator internis, which runs through the lesser sciatic notch. So you can imagine as you peel that off, your finger will naturally follow into the lesser sciatic notch, where you can insert a retractor. So this image shows you the 2 retractors, one in the greater sciatic notch, one in the lesser sciatic notch. The greater sciatic notch retractor is a little bit chunkier. It protects the sciatic nerve. You can see just underneath that. And then the lesser sciatic notch retractor also protects the sciatic nerve, but there's a layer of short external rotators between the retractor and the nerve. So at this point, you can extend the exposure slightly more distal, and some textbooks talk about taking the quadratus femoris off the GT, but as I said earlier, I try to avoid that in order to avoid damaging that blood vessel. And so what I do is I use a diathermy and just take a little bit off the quadratus femoris off its origin at the ischium, or the aspect of the posterior column that you need to expose. And at this point, we're hoping to protect the sciatic nerve, and so we need to relax the sciatic nerve, take the stretch of the sciatic nerve, and in order to do that, you need to extend the hip and flex the knee. And the way I do this, and the way I try not to forget to do this, is I have the patient's shin resting on my abdomen, and in that way I can flex the knee and extend the hip whilst having my hands free still to operate on the acetabulum. And so this is the kind of position that I'm in when I'm operating at the back of the posterior column, trying to avoid stretching the sciatic nerve. So the last rule is do not perform a capsulotomy. So in a lot of textbooks and even on the AO website, you will see this suggestion that at this point you should perform a T capsulotomy. And in some scenarios that is appropriate, but in this scenario of an acetabular fracture with a posterior wall or a posterior column, doing a capsulotomy is not recommended. Certainly, I don't think it's a good idea. So this image just demonstrates to you why that's not a good idea. So you've got the green rubbery thing on this model, which represents the capsule. And behind this, you can see the fracture lines here and here of the posterior wall. And so what you don't want to do is to incise that capsule. You want to keep that capsule completely intact, but to open up the fracture from the posterior of the posterior wall. And so you can see on this image on the right, we've managed to get a periosteal elevator into the fracture and affecting the marginal depression of the acetabular fracture by going through the fracture. Not that dissimilar to any other kind of intra-articular approach you would take. For example, a tibial plateau fracture, you would go through the fracture and elevate the fragment. So this is the same sort of thing. But you can see how you preserve this capsular labral attachment to the small bony fragment, thereby preserving the blood supply, and actually makes things a lot easier when it comes to reconstructing with plates and screws. So don't perform a capsulotomy, and then this image shows how you can reduce the posterior wall fracture with lag screws and then neutralize it with a plate. And finally, the closure, and a part of the closure that's really crucial is to avoid this complication following an acetabular fracture. This is, you can see, quite extensive HO following fixation of the acetabulum. And there are lots of factors that can affect the progression of HO post-fixation. But for me, the key is to debride the gluteus minimus muscle, obviously as much as looks contused and bruised, but also when you're doing the approach, it's also useful to excise gluteus minimus so that it allows you to have better exposure of the acetabulum and puts less force through the minimus muscles, and thereby creating more trauma to the minimus muscle. So that's a key element of finishing up this this approach. And finally, you can repair the short external rotators. Obviously, it's not like the posterior approach where you have to drill through the GT. You've still got the cuff on the GT side to repair onto with sutures. And at this point, it's really disappointing to inadvertently jab the vessel that you've been trying to preserve the whole way through. So be careful not to damage the blood vessel to the femoral head. And finally, repair the gluteus maximus insertion to avoid any asymmetry in the buttock region. And that's the Kохера Lангенbeka approach.